Yeah, back online. So, yeah, what can we say about Murphy? So, if we look at the global numbers of people on more or less estimate on the earth, it's 8.1 billion, of which women are half of the population. But what's more important is to see that at age 60 to 64, female majority actually begins. So at age 50 to 54, we are near parity, and this is very important. So if you look at the older population, we can see that females significantly outnumber men in a later stage of their lives. So what I wanted to do was actually differentiate and put different categories of female life cycles out there to make it a little bit more digestible for to look at groups of females. And then the first group I'm talking about is puberty, and that normally ranges about 18 and 13 years. And then must remember that puberty is a sequence of certain developments that's happening. It's not just one thing. Then we look at the reproductive years, and those are females that are still menstruating, and then premenopausal years, late 40s up to menopause. And then once I talk about the menopause and the climacteric years, and then the postmenopause, and why I put this down is there's such a confusion about menopause or climacteric years or postmenopausal years. So I will try to differentiate between those as well. So if I talk about hormones and hormone phases with women, then this graph actually helps me a lot. So the red line is the estrogen. So that is our main hormone. And when patients are coming to talk about testosterone, I say females are not small men. So estrogen is our hormone. And the hormonal phases are all about estrogen. Of course, it's a relation of estrogen to progesterone as well, but it's actually estrogen that we talk about. So then you can see the red line at around about 50 starts to drop. So menopausal years are surrounding menopause. So what is menopause? Menopause is a happening. It's the last period in your life's name. Your first period in your life also has a name, and that is menarche. So menopause happens at around about age 51, and then estrogen declines, and then you hit rock bottom a year after your last period, and then your postmenopausal years actually started. So the decline, recline, those are the climacteric years, and then mid-40s to up to menopause line are the premenopausal years. So puberty, we need to remember this is a very special group of girls. So there is a lot happening in their lives. So developmental, psychological, due to the development stages that they go through, emotional support that they do need. And this is a very critical stage of a girl's life and a woman's life to start intervening with certain habits and, of course, sexual behavior. Although they are very young, we need to talk about safe sex, and in some instances, those girls also need a contraception. So what interventions should we do and know about during puberty that can have lasting effects during their reproductive and later years? So the number one thing, of course, that we must remember is bone mass. So bone mass accumulation during the puberty is actually very critical to the development of peak bone mass. And peak bone mass is a major determinant of the risk for developing of osteoporosis later in life. So nutrition and hormone exposure during puberty is of high importance. So some of the sports practices send their little girls to me that is exercising a lot, they don't menstruate, and then they get stress fractures. So we need to know that this is a very important developmental phase. So about half of the body calcium is accrued during puberty in females. And the peak velocity in bone mineral accretion occurs at menarche. So menarche is the first menstruation, and that is round about at age 12 to 14. And approximately 9 to 12 months, a year before the first period, after a peak velocity is reached, girls start to menstruate. So the first sign of puberty is actually growth, the growth spurt. So if you look at elastic, so then the bones are just like that. So they get their peak velocity of growth, and then the bone stretches out. And then you can think about the bone as an empty tube. So now we need to fill that tube with calcium and magnesium and vitamin D. So those bones need to mineralize to actually get to the peak bone mass. So this window of opportunity to maximize the peak bone mass is actually very narrow and during the puberty years. And one study actually reported that 86% of spinal bone mass is acquired by the age of 14 years in girls. So when we look at bone density measurements in female in the menopause, and they have strong hips and osteoporosis in the vertebrae, then this is most probably the reason that something happened around puberty. So what is the daily allowance of calcium between the age of 9 and 18? And that is 1,300 milligrams a day. I don't speak about vitamin D. That's round about between 1,000 to 5,000 international units. And magnesium is round about 300 to 500 milligrams per day. And the most important thing about magnesium is it doesn't matter what magnesium salt you actually take. It all depends on you need to divide the dosages. So, and then what is the next intervention that we need to talk about? And that is vaccinations. So the human papillomavirus vaccine is with us for more than a decade now. And if you look at vaccination ages, then we start as early as age 9. So the sooner you start vaccinating, the better uptake of the vaccine is. So, but in general, they will do and have their vaccinations about 11 and 12 years. And then what is available at the moment is Gardasil 9 and then Cervarix. So if we look at the studies, because there's a lot of resistance still to this vaccine, and then if we look at clinical trials, we see that these vaccines are quite effective. But if we look at real world effectiveness, this is what we are interested in, and then we can see that the efficacy is round about between 88 and 90%. And some regions actually reported higher efficacy rates. So what other types of vaccines do we need to do during puberty? And that is, of course, our TDAP booster at around about 11 to 12 years. And I think our audience this morning will know more about meningococcal vaccines than I do, but we mustn't forget that we can start with the first dose at age 11 to 12, and then, of course, influenza, and then we need to look at catch-up vaccines. So we get different meningococcal vaccines. So the one that you can start at an early age is the conjugated vaccines. And then a little bit later, of course, is the serogroup B, and then, of course, the pentavalent meningococcal vaccines. So if we look at the reproductive years, so what are the 5 burning issues that we are dealing with in our female population? And the number 1 is maternal health complications. So, and this remains the leading cause of death in women in many low and middle income countries. So, and it's bleeding and hypertensive disorders, and then infections, and very important and safe abortions. So if you look at maternal mortality, then we see the world mortality rate is around about 211 out of 100,000 live births. So that means there are 300,000 women a year that is dying, and that equals to 830 a day. So if you look at an Airbus that actually contains 850 people per flight, then it is as if one Airbus is falling every single day, and that's a lot. So in some countries, the maternal mortality rate is staggeringly high. It's 1 out of 15, and then 99 of all maternal deaths, unfortunately, happens in developing countries, where 76% of the world population is based. So third world countries and safe abortions are the leading cause, and then global data, abortions accounts for 7.9% of maternal mortality, of which the majority are unplanned pregnancies that are aborted. And then blood clots. 3.2% of maternal mortality relates to blood clots. So if we talk about contraception, then we need to see it in perspective, because a lot of females are going onto social media and then they say, no, my oral contraceptive is very unsafe. It gives blood clots. But if you look at the risk on an oral contraceptive in a young female, the risk for a blood clot is around about 12 out of 100,000 women years. Whereas if you compare that with a pregnancy, the blood clot risk is between 60 and 100 out of 100,000 women years. So actually, oral contraceptives protects women from dying during a pregnancy of blood clots. So the number 2 burning issue, of course, is sexually transmitted diseases, including HIV. And for us, of course, it relates to infertility and chronic pelvic disease and cervical cancer. And in young women, 60% of HIV infections happens in sub-Saharan in young females. So what is a number 3 burning issue? And that is family planning and contraception. And we saw that in our first slide, is that maternal mortality, of course, is the leading cause of death. So we need to talk about family planning and contraception with these patients. So we can see that lack of access to family planning leads to unintended pregnancies, of which we know that unsafe abortions are the leading cause of maternal deaths. So the background and history of contraception is, if we look at the literature, it is actually shocking to note that the clinician's anecdotal experience with contraceptive methods is truly insufficient to actually provide the accurate information necessary for a patient counseling. And still, we do not in all the cases inform ourselves of what is available and what are the risks and what is out there for female contraceptives. So what do we want to achieve with contraception? And that is, we want to have conception. So we don't want them to fall pregnant. So in that regard, there are different efficacy rates of the different methods. So there's not one method, but a lot of options, and it's not only one fits all. We need to talk about all the type of contraceptions to a patient. And if we look at the literature and single out one factor that is the biggest factor for usage of a specific method, then it is the doctor. So we really need to talk about contraception to patients in all the different methods. So if a doctor cannot fit the intrauterine device, of course, that doctor will not put it up as a number 1 contraceptive method and will actually leave it at the sideline. So we need to rethink contraception for specific patients, and we need to ask patients, and studies actually showed that doctors actually don't speak to patients of what patients want, but actually what doctors want for patients. So then we know that there's a difference of groups of contraception, and that is systemic versus local. We also have a national contraceptive guideline. So the newest one was started in 2019 and finished in 2021. So there are quite new guidelines on the usage of contraception. What is very important is that we know about the medical eligibility criteria for contraceptive use. So what is safe, and then what is very dangerous for patients that we should not use. And then there are different methods. So I use this as a tool during my consultation with patients. So what are available, what are the pros, what are the cons, and what are the efficacy rates of different types of contraception. And then, of course, you need to get consent of the patient. So when I start contraception, all my patients will sign consent. So if a patient visits me and she is already on contraception, then I don't necessarily get consent. So then the long-acting reversible contraception. So even the government acknowledged that this is the most effective contraceptive method, and it's actually the continuation rate is much more superior than oral contraceptives. So, and if you look at the efficacy rate on the graphs, then you can see it's much more, so the pregnancy, they show the pregnancy risk. So the intrauterine system figure is the third one from the right. So you can see that is very, very effective. So the pregnancy rate is very low. So then the number 4 burning issue, of course, are cancers of the reproductive organs. And the number 1 cancer, of course, is cervical cancer. And we know that it is 97% of cervical cancers are attributable to the human papilloma virus. And that's why we need to vaccinate patients as during the puberty years. Number 2 is breast cancer. Of course, breast cancer became number 1 as females aging, and then ovarian and endometrial cancers. So breast cancer, so we need to do, so we always talk about screening because that is what we want to do. We want to do preventative care for patients. So then mammography is every 1 to 2 years. It depends on the density of the breast tissue and the availability of the tests. And then, of course, clinical breast examination, it's not that accurate. But we always urge patients to do self-breast examinations. Cervical cancer, so every country do have their own specific guidelines to do cervical cancers. And when I was a registrar, one of the questions in our last paper was, what is the South African stance on cervical screening? And then very sad to say we did not have a cervical screening program. We had opportunistic screening. Nowadays, we do have a screening program, and we say at least 1 pap smear in a woman's life, or at least 1 every 10 years. So, and that's why the human papilloma molecular testing is so important, because if we just do the human papilloma molecular testing, then we can screen patients in population-based 3 to 5 years. So, of course, in private practice, we do it more often. Colon cancer is a women's number 3 cancer. And when I do send stool tests away, my patients are always complaining. They say, this is an ugly test. I said, yeah, well, I think colon cancer is more ugly. So I start doing stool tests from age 40. And then colonoscopies once every 10 years from age 50. In America, they start a little bit sooner at age 45. So lung cancer, very interesting. So number 4 is lung cancer. And just to show that it is females are still smoking. And then, of course, there are other reasons for lung cancer, like passive smoking. And so the specific guidelines will be if it's a heavy smoker, more than 2-pack years, they actually have to have chest x-rays. And what I also do is I send my patients for a urine cytology because that is easy because bladder cancer is also very common in smoking patients. And then ovarian cancer. So there's not a specific screening guideline, but we do pelvic ultrasounds, and that is a very important tool to screen. We don't do annual CA125s unless a patient does have a specific gene, like the BRCA mutation, and a strong family history for ovarian cancer. Then we do it on an annual basis. And then don't forget mental health disorders. We're still stuck with gender-based violence and, of course, maternal stress. And suicide is a leading cause of death in young women younger than 30. So what about the transition years or the climacteric years? And I put this space photograph of the question mark there because I think sometimes we find ourselves in a myriad of hormonal complaints and we don't know where we are. So, and this is actually a very beautiful picture. This is a piece of cosmic punctuation, and it's actually a result of a rare alignment between two distant galaxies. And it is a concept called gravitational lensing. So what questions do we need to ask ourselves during the climacteric years? And number one is, what type of contraception is safe or safest? So if you look at American data, the most unplanned pregnancies actually happens between age 40 and 49. So we need to prevent pregnancies in that age group. And then it's very important because it's a very common question, when should we stop contraception and when should we stop or start menopausal hormone therapy? So we don't talk about hormone replacement therapy anymore because we cannot replace the hormones that a patient had, the levels of estrogen during the reproductive years, because we will kill females when they're getting older and give them high levels of estrogen. So we just give a drop in the bucket. So it's around about a 6 or an 8 of estrogen that we do give them to maintain a certain organ health. So a quick guide for stopping contraception is females over 50. We normally try to stop estrogen-containing contraception. So we give progesterone-only contraception, and then we test the FSH levels. And then if you have 2 FSH levels higher than 30, then after a year you can stop the contraception. If it is less than 30, then you need to continue with the contraception. So it's very important sometimes to include blood tests in what decision you have to make. So just another easy one is natural fertility decline after 40 years, but one can still fall pregnant very late in your 40s. And then, it depends on when a female is stopping a menstrual period. So younger than 50, you need to continue for 2 years, older than 50, at least 1 year after no menstruation. So then the postmenopausal phase, and so that is always something that we need to face. I always tell patients, if you live long enough, there are 2 things that you're certain of: death and menopause. So, and then the 7 dwarfs of menopause is witchy, sweaty, itchy, sleeplessly, busty, forgetful. Then my husband will tell me, "Oh, doctor, I'm psycho. You have to give me some hormones." So, but if we look at the menopause and we look at what is the number 1 killer in women, it's actually a physician's disease. It's cardiovascular disease. More than half of females in the menopause, so some figures will say 56% of females in the menopause die due to cardiovascular disease versus 3% of females that die due to breast cancer. So if we talk hormone therapy in the menopause, females will say, I don't want to use a hormone therapy because I will die due to breast cancer. But actually the estrogen is one of the interventions that we can do to actually lower the risk for cardiovascular disease. So the number 2 killer, as we know, is cancer. The number 3 one is lung diseases, so respiratory diseases. And then number 4, diabetic related diseases. And then number 5, osteoporosis. So we need to be mindful when we screen patients in the different phases of their lives, what are applicable in that specific phase. So heart disease. So as I've mentioned, 56% of women die due to cardiovascular disease in the menopause, and very few people actually realize that this is the leading cause of death. So the CDC actually reported that this disease was responsible for 1 in 5 female deaths in 2019, and it is actually most probably higher. So many risk factors can be helped. In fact, in 95% of deaths from heart disease can be lowered. And so we need to intervene and talk about smoking, high blood pressure, cholesterol, overweight, physical activity, and diabetes. So when I do screen my patients and their cholesterol is elevated, I will put them on a lifestyle change program, ask them to see a dietitian and retest, and if the cholesterol stays high, I will refer them to a colleague, a physician, to do a risk stratification to see whether they need statins or not. And I think this is very important to actually intervene really early. And then smokers, they have a 6-time higher, more likely rate than non-smokers to suffer from a heart attack. So this is very important. And I tell my patients, I need to tell you what you need to know, not what you want to know. And I'm very straightforward for what they need to do with lifestyle changes. So we need to know the numbers, and that is, of course, your blood pressure and your cholesterol and your glucose. So, and then I think the physicians are much better equipped with numbers than we are, but we need to respond. And then, of course, healthy diet and activity, that is very important. I read an article where they spoke about people working behind their desks, and even if you just stand up every hour and move for 2 minutes, then you can actually expand your life. So, and then, of course, stop smoking. So even modest weight loss is of utmost importance. And then, of course, managing stress, and then limit alcohol. So, or avoid it completely, or a less intake. And I tell my patients as well, newer study says alcohol is carcinogenic, so as smoking. So it's important to convey that information. And females who are taking more than 4 glasses of wine a week up their risk for breast cancer considerably. So I usually tell my patients, please avoid alcohol or take less alcohol. So hormone therapy, so menopausal hormone therapy is not recommended solely for heart disease prevention. So the indication to start menopausal hormone therapy is still the climacteric symptoms. And remember that red line that is declining before menopause. Menopause is the name of the last period of a woman's life. They will start having hot flashes, but if they're still menstruating, they're not in menopause. So a lot of doctors think hot flashes and night sweats equals menopause or postmenopausal phase. It's not. It's 1 year after last menstruation, then the estrogen is rock bottom, and then you start considering menopausal hormone therapy in those patients. So, and then the only indication to start late, and that is after age 65, will be a low bone mass in those women. But if you start giving, the irony is if you give hormone therapy, you do intervene with chronic diseases, although that's not the indication to start hormone therapy. but there are positive spin-offs on bone, on heart. You lower your risk for colon cancer considerably. So even in women with a family history of colon cancer, we consider that also as a good indication to actually give menopausal hormone therapy. Just to touch on the cardiovascular disease risk. So this is a graph. The dark part represents the males, and the white part of the graph represents the females. And we can see in the reproductive years, when women have a lot of estrogen, their risk for cardiovascular disease is very low. And one of the reasons attributable to cardiovascular disease in young, healthy males, sometimes, of course, we need to look at the blood pressure, cholesterol, and things like that, might also be a role of testosterone in on the lipid profile. So that's why I don't give testosterone in women, because it is detrimental to the lipid profile. They need regular checkups. Of course, patients will ask, "Doctor, can I come and see you in 5 years' time?" We are dynamic creatures. So then I say, well, if you don't have time to be sick now, you don't have time to be sick in the future. So rather be preventative and visit and screen. And then with that, we actually lower or compress our morbidity, because that is what we want to do. If we don't intervene, we will follow the original line. So if we do a little bit of intervention, that actually already postponed morbidity. And if we do regular checkups and start treating patients very early, then we can actually have a much bigger impact. So we have to screen. So what I do in my practice, I do certain blood tests. Of course, we need to screen for colon cancer, and then mammography tests, and then cervical screening. And of course, we need to look at the bones. Thank you so much.
Thank you so much, Kyleena. I think first, my apology again for people online. This was something unexpected, but think about the positive aspect of it. You never know what could have happened if you're not listening to this present in the last 15 minutes. Could have been worse. So at least you're in the right place. Thank you. Just for me, it's a matter of comment. One was about the venous thromboembolism in the patient on contraception. And I always believe that you must always ask yourself questions whether these patients develop it because of the contraception, or you must look for underlying process, because most of people might ask what makes this particular percentage of patients so important. So it basically means you must look for something else. There might be underlying process that might have contributed for them to have a venous thromboembolism. And I think it's very important. Don't just blame the contraception without excluding all the known causes that can cause the venous thrombosis. And the second question, taken comments regarding the role of colonoscopy in females. Again, I think we have to be very careful that colonoscopy, obviously the first colonoscopy is very important in everybody's life. And that determines how frequent your colonoscopy will be. Now, if anybody with a family history of colon cancers or polyps during their first colonoscopies, probably have more frequent, shorter duration of colonoscopies as compared to those with nothing on their first colonoscopy, and that 10 years become appropriate. So I think your doctor should guide you regarding how frequent your colonoscopy should be, and the same thing will guide you regarding contraception. So contraception is very important, that you need to actually see your gynecologist, not by a general practitioner, about the role of contraception. Because again, I think there's a lot of indication or contraindication of contraception, depending on your age profile, depending on your autoimmune disease, and depending on your comorbidities. So it's very important to see a gynecologist on those aspects. So I'm really quite grateful for your presentations, and it's really quite very insightful, beautiful. Sorry for all this, but I think probably all our patients and probably our doctors could be able to listen online on podcast, which is available. And yeah, thank you.
You're most welcome. Thanks, Emmanuel. Any questions?
Any question online? Please, one question or two. Okay, great. Is it?
Okay, well, thank you, everybody.
Yeah, I think our biggest thing, or that we see a lot, is patients who present with DVTs, pulmonary embolisms, that is on contraceptives, no, or hormone replacement, and then stopping that, trying to find another solution. Obviously, looking for a complication, but mostly it's estrogen. So, what are the options there that we can do?
So we are actually very excited about a new treatment for hot flashes. Unfortunately, it's not available in South Africa. They do use it in America already for a few years. So it's brain receptor blockers at the thermostat that actually affects the kisspectin and the candy areas in your brain. So that's non-hormonal. So, and that's very effective. So we are waiting for that. And that is the hot flash a symptom. But females also complain about dry vaginas, and especially patients on estrogen blockers with breast cancer. So for them, it's really a huge struggle to have dry vaginas. And so we have a brand new estrogen, it's estriol, that's not being absorbed systemically. And it's also combined with Probiflora. So it's a tablet that females can insert into the vagina, and even patients with intact uteruses, because we were always concerned with the previous products that even the estradiol tablets that and the creams that were available could be systemically absorbed and even into the endometrium. So GP, sometimes I get patients that treat patients with vaginal estradiol, and then they think it will not have an effect on the systemic breast cancer or on the endometrial lining, but they're wrong. So, but now with this new product, we can actually give patients with blood clots and breast cancer and intact uteruses who cannot use vaginal estrogen these products. So luckily we have alternatives at the moment. So that just one thing that I also see in my practice concerning blood clots, one must remember that the total contraindication for estrogen containing contraceptives are smoking. So then I get a lot of patients 40 plus years and then they're still on oral contraceptives. One must always talk about smoking. Smoking after 35 years is a total contraindication for estrogen containing hormones. So please, and it's not only because of blood clots, it's because of myocardial infarctions. So you at the risk extremely much more. So you need to convert those patients to either intrauterine contraception or a surgery. So that's always important to ask.
I'm just asking for a tip.
Yeah.
I work with a lot of women. When would I see the light is saying green or yellow, depending on their hormones? Because would I say, oh, this is menopause, just do I need to walk away, say nothing? When do we actually make sure that our interaction remains smooth?
If she's still menstruating, Emmanuel, then you can walk away. Then it's not menopause.
Okay.
And you do get females. I actually saw a woman the other day. She was 56 and she's still menstruating. But then you need to be very careful because they need to stop. And then you're worried about estrogen exposure on the endometrium. So, but yeah, in general, when a woman is still menstruating, you can't blame hormones.
Okay, great. So no excuse for that.
Yeah.
Great. Thank you.
You're welcome.
So there was just again a few questions about where they can get the slideshow. So
No, we will. I think
It will be on.
podcast. We'll edit all the delays and everything, and should be available at least by Monday. And they're really also for you guys. This is a very good presentation that has, or it was done yesterday on hypoglycemia, how to manage them. It's really very beautiful. That I really would like all of you maybe to watch it. And then perhaps kind of, And then maybe within ourselves, we could kind of develop guidelines, actually how to manage those patients. And I think also one of the things that based on Kyleena's presentation, obviously will be online, but I think once you have females in casualty, now you know what to do, what to look for, especially when these people come over to you in casualty, and then think about leaving us from bosses, take history of contraceptions and everything. So yes, everything will be available, Danny, on the podcast. You guys have access to the podcast. But again, as Leanne said today, please, we have the same link for the same presentation every Wednesday. Thank you.
Just to mention, the slides and the presentation is on YouTube under Sanocare Breath of Hope is where you find it.
The keyword is breath of hope.
Breath of Hope.
It's the only one.